challenging cases of acute ischemic stroke, which we did encounter in our daily clinical practice. It gives me an immense pleasure to welcome our host director for the program, Dr. Jayanto Roy, sir. Sir has been working for this program with us for almost more than 2 years. It was the first program which we started almost 2 years back under the moderation of Dr. Jayanto Roy, sir. Sir would be a course director for this session. Sir is a director of a stroke program and a senior consultant at Department of Neurology at Institute Sciences, Kolkata. Sir has been a recipient of 2005 American Society of Neuroimaging William N. McKinney Award for the best manuscript based on clinical research and neurosonology. He is a certified neurosonology accredited by American Society of Neuroimaging. He has made many scientific presentations in reputed international forums, including European Stroke Organization Conference, World Stroke Congress, and many others. He is a member of editorial board of a Journal of Stroke Medicine, a member of Global Executive Committee, MT 2020, Executive Committee member for the Society of Neurosonology India, and member of Educational Committee, Joint World Stroke Congress, Hyderabad 2016. Thank you very much, sir, being a part of this program. We always love your participation and your comments, which are very, very appreciated across the country. Thank you very much, sir.
Thank you.
At the same time, I would like to welcome our moderator for the day, Dr. Arun Garg, sir. He's the head of stroke neurology at Medanta, the Medicity, and he is working with the vision to develop brain rescue program for immediate and long-term management of individuals with stroke, covering the entire North India with an epicenter of Medanta. He has pioneered role of thrombolysis in acute stroke in this part of the country, and he has collaborated with the University of Massachusetts, USA for stroke prevention, education, treatment, rehabilitation, and clinical research. He has a keen interest in a post-stroke neuro rehabilitation with inputs from multidisciplinary team. He is an organizer for the concept designer for Essentials of Acute Stroke Treatment East, a training course related to management of acute stroke aimed for physicians and healthcare providers at primary and secondary level hospital. He has published many national and international journals and has a keen interest in teaching. Sir will be joining shortly. And now I would like to welcome our second moderator for the day, Dr. Santosh Sontakke. He is a consultant neurologist at Ruby Hall Clinic, Pune, and he's practicing as a consultant neurologist for more than 13 years now, and he's working as a principal. He has worked and working as a principal investigators in many groundbreaking research like a peripheral neuropathy trial, myasthenia gravis trial, multiple sclerosis, and tinnitus in a stroke thrombolysis. We welcome all our faculty. Now I would like to welcome our expert speaker for the day, Dr. Gaurav Shah. He's working with Divine Kutch Life Care Super Speciality Hospital at Bhuj, and he has a special interest in stroke and epilepsy. I would now like to welcome our expert speaker, Dr. Varun Rehani. He is a consultant neurologist at BLK Hospital, New Delhi. He has a special interest in stroke, headache, multiple sclerosis, and other demyelinating disorders, and meningoencephalopathy, epilepsy, Parkinson's disease, and movement disorder. We welcome all the expert speakers for the day as well. So, sir, if you permit me and if you allow me, I would like to present, sir, 4 slides, which is a recent update of ESO. And I think the audience who is listening across the country, they will find it really interesting. If you permit me, I will just share 4 slides, and then you can give the expert commentary, and then we can start this section, sir.
Go ahead, please.
So, okay, so there are very exciting and new development which has happened in the last month, and I really want to present in front of you. So this is a European Stroke Organization expedited recommendation on tenecteplase for acute ischemic stroke, and this was just published maybe 7 to 10 days back. And very interestingly, they have given the evidence-based recommendation and also expert consensus statement. So their first evidence-based recommendation is for AIS less than 4.5 hours, and which says that tinactopase is a safe and effective alternative. So the recommendation says that for the patient with acute ischemic stroke of 4.5 hours duration who are eligible for intravenous thrombolysis, tinactopase at the dose of 0.25 milligram per kg can be used as a safe and effective alternative to alteplase 0.9 milligram per kg. And the quality of evidence for this is a moderate evidence, and the strength of recommendation is strong. So these ESO evidence-based recommendations are giving tinactopase as a safe and effective alternative to that of alteplase in the patients who are reaching less than 4.5 hours. Now, coming to their second recommendation, in the facility for pre-hospital management with a mobile stroke unit, and where the tinactopase can be preferred. So the recommendation is saying that for the patients with acute ischemic stroke of less than 4.5 hours duration with pre-hospital management with a mobile stroke unit who are eligible for intravenous thrombolysis, they suggest tinactopase 0.25 milligram per kg over alteplase 0.9 milligram kg to increase the rate of early reperfusion and shorten the time of imaging to the treatment initiation. Although at this point of time, it has a low quality of evidence because of the limited number of studies and a weak recommendation, but they are saying that tinactopase is preferred in a mobile stroke care unit. Now, coming to LVO, the evidence-based recommendation clearly says that the patients who are with a large vessel occlusion and they are reaching within 4.5 hours of duration, and those who are eligible for intravenous thrombolysis, this ESO recommend tinactopase 2.25 milligram per kg over alteplase, and intravenous thrombolysis should not delay the mechanical thrombectomy. So here in LVO, they are always saying, and this recommendation is saying that tinactopase is preferred over the alteplase, and this is also a moderate quality evidence, and a strength of recommendations are strong. Now, coming to the next part, acute ischemic stroke on awakening from sleep or acute ischemic stroke of unknown onset. And there are some expert consensus statement for the patients with acute ischemic stroke on awakening from sleep and the acute ischemic stroke of unknown onset who are eligible for intravenous thrombosis. There continued to be uncertainty over the potential benefits and harm of tinactopase compared to the alteplase, and that's why they come up with the expert consensus statement. And the member of working group committee, they suggest that tinactopase 0.25 milligram per kg could be a reasonable alternative to the alteplase 0.9 milligram per kg in patients with acute ischemic stroke on awakening from sleep or acute ischemic stroke of unknown onset, where who are eligible for intravenous thrombolysis based on after selection with advanced imaging of a flare mismatch or a perfusion mismatch. And interestingly, 9 out of 9 members are voted in favor of this recommendation. So that's very interesting to know. And then another, what about the thrombectomy capable centers? So they are saying that for LVO, don't skip IVT if MT is scheduled. For the patients with a large vessel occlusion and acute ischemic stroke of less than 4.5 hours duration and who are eligible for intravenous thrombolysis and who are directly admitted to the thrombectomy capable center, all members of working group members suggested that IVT with tinactopase of 0.25 milligram per kg or 0.4 milligram per kg over skipping the IVT. They also mentioned that for the patients with a large vessel occlusion with acute ischemic stroke of less than 4.5 hour duration and who are eligible for thrombolysis and who are admitted to the centers without mechanical thrombectomy capability, all member of working group suggested IVT with tinactopase 0.25 milligram followed by rapid transfer to the thrombectomy centers can be done. And it's also a 9 out of 9 voting. I think this was a really very interesting, what you call as a development, which has happened in last 10 to 15 days back, and that's why I thought I would just share it so that our faculty can give their expert commentary, and then we can move ahead for the case presentation. Thank you very much, sir, and over to you, sir.
Thank you, Dr. Unkar. First of all, good morning to everyone for this KT meeting for today, and those who have been following it and participating in it, and as a faculty or as an audience for the last couple of years, you must have found this weekend meeting a very comfortable, cozy, but at the same time, very interesting, because it has kept the flow of the program very well. And I've been part of this program for almost, I never missed probably more than 1 or 2 sessions in the last 2 years. So I have been enjoying that thoroughly. And today we have my very good friend, Dr. Arun Garg has joined. Dr. Garg?
Yeah.
Hi, good morning. How are you?
Morning.
So he's here. I'm very happy to have him on board, and Dr. Suntake as another moderator, and 2 very bright young neurologists who will be presenting their cases. And I hope the audience will enjoy the discussion for next 40 minutes. And regarding the recent developments which Dr. Onkar has just presented, we all know that it was coming. I'm excited, I'm happy, but I'm not surprised looking at the results, because we all felt that the tenecteplase has come to stay. And of course, we need some time to create more data and evidence, which is evidently supportive to our idea that this is a very good drug. And it has already changed our practice. All those indications mentioned here, IVTPA under 4.5 hours, LVO, even beyond 4.5 hours, wake up stroke. We have been using tenecteplase regularly now. We are happy with that. So I think the practice is changing and will keep changing. So any comment, Dr. Garg, on this?
Sorry.
Dr. Arun Garg?
We have experienced that tenecteplase is effective, and yes, we have started using it more frequently. But still, I'll keep my fingers crossed. Let us see more data. We are waiting for more data to come. Definitely, in large vessel occlusion, it's effective, safe, and it helps in mechanical thrombectomy is more effective when it is combined with tenecteplase. So it's right. Effective in certain cases. Situations, it's effective.
Right. Thank you. So, Dr. Onkar, I think we should proceed with the presentation.
Yes, sir. We should proceed with the case. So, I would request Dr. Gaurav Shah to start his case, share his slides, and start his case. Dr. Gaurav,
take a second.
Yeah. Would you like to share your slides?
Yes, sir. So I'm facing some technical. I'll take 5 minutes for sharing my slides if you allow.
Dr. Varun, you would like to go ahead first?
No issues at all. I'll do that. Okay, so are my slides visible?
Yes, you are. Please go ahead.
Just a minute, sir. Just a minute. So should I start?
Please.
Please start.
Okay, thank you. Good morning, everyone. First and foremost, thank you to the Emcure Pharmaceuticals for providing me this opportunity again this year. Having performed one interesting case last year, I'll be presenting another case, this time a bit difficult yet interesting. I would like to again say thank you to Dr. Jayanta Roy. And I would also wish a very good morning to Dr. Arun Garg sir, who I'm meeting again after he had passed me in my DNB examination when I was in Army Hospital. And good morning to Dr. Santosh as well, who I have not met. So going straight ahead with my case, a 51-year-old male, a known case of dilated cardiomyopathy with low ejection fraction, was recently admitted in the orthopedics department with a fracture of the right tibia and operated 6 days back with open reduction and internal fixation. The patient had an in-hospital sudden neurological deterioration with a sudden onset left-sided hemiparesis and drooping of both the eyelids at 8 a.m. in the morning. At the time of onset of ictus, the patient was in the HDU and had an awakening at around 6 a.m. and had requested for water to the nursing staff. The patient was clinically examined. Findings were observed by the resident on call, and the video was shared to us. So clearly we can notice the patient has very poor alertness, requires repeated stimulation. There is a definite focality with poor power in the left upper limb, and the patient is unable to open his eyes. He's keeping his eyes closed. As we can see, he was unable to lift his leg as well. And when he was trying to open his eyes, he was using his frontalis muscle. However, the eyelids did not open. So the onset, as we noticed, was at 6 a.m. He was last known normal to be at around 6 a.m. The NHSS was documented to be around 11. Points given for alertness, for motor deficit, had a mild speech defect also. The fluency was reduced. He was slightly dysarthric, mild dysarthric. So a score of 11 was given to this patient. So now, when we have had this, the dilemma that we were dealing with at that moment was it a stroke or was it an encephalopathy? Why? Because the consciousness was down. The patient, although had a definite focality on the left side, but was also not moving the right side as good as as a normal person. So whether the person was having any sepsis or other thing, that was another doubt. And if stroke, where is the lesion? Is it a bilateral cardioembolic showering? Is it involving the brainstem? Is it involving the thalamus? And what is the etiology? Is it a large vessel? Is it a cardioembolic or a fat emboli? These were all the doubts that were there in our mind while we were planning to do the next imaging. And which imaging should we do? Should we do the CT and CT perfusion or MRI? That was in our mind what to do. And even if supposedly the patient turns out to have stroke, ischemic stroke, the issues was that he has had a recent surgery and he was on prophylactic anticoagulation for DVT. So subsequently, we ordered the MRI brain and it was done at around 8:28 a.m. And what was noticed was that there were diffusion abnormalities, signal abnormalities involving the area of cerebellum, a tiny speck involving also the midbrain area and the thalamus, predominantly the bilateral paramedian thalamus. These were within even 2.5 hours were showing flare positivity that can be noticed. However, on the angiogram, there was no large vessel occlusion that was noticed. In view of the patient that was being in the window period within 4.5 hours, the patient was being considered for IV thrombolysis, but there were a few caveats. The patient had had a recent major surgery, which was 6 days old. Patient was on prophylactic anticoagulant, and there was subtle flare positivity. So as we know that with the routine IV thrombolysis, there is almost a 6 to 7% risk of intracranial bleed. However, in the view of above mentioned caveats, the caregivers were sensitized that they were going to be a higher than normal risk of bleeding, and consent was sought for proceeding with thrombolysis, and patient even after discussion with the primary team that there may be a higher risk of surgical site bleeding. After the consent, verbal consent from the primary team as well, patient was then thrombolized with a written consent from the attendants with tenectase at a dose of 0.25 mg per kg at 9:15 a.m. By the end of second day, he had improved in his stroke scores, and by the time of discharge, he had recovered a major part of his deficit, but continued to have ptosis, vertical gaze palsy, and mild left upper limb weakness. So as we can see, the patient's alertness has been better on the second day. The power which was, the patient was not able to move even against the gravity, has been able to move his left upper limb. And there is an obvious ptosis, bilateral ptosis, and a vertical gaze palsy. CT had done post 24-hour thrombolysis had shown no bleeding. When the patient was discharged, the Holter had shown multiple runs of AF, and patient was discharged on anticoagulant and single antiplatelet with a statin. And the etiology for the stroke turned out to be cardioembolic in this case. Now coming to discussion. So when we have involvement of the midbrain, the rostral midbrain and the thalamus, the clinical radiological possibilities that we have is the infarction of the artery of Percheron, a top of basilar artery infarction, a deep CVT, or for diffusion abnormalities, we may also have infiltrative neoplasms of the thalamus. So what happens with the artery of Percheron, as we know, is a anatomical variation in which it is a single unpaired trunk arising from the PCA territory, P1 part, and supplies both parts of the rostral midbrain as well as the thalamus, and involves predominantly the paramedian thalamus, and may also supply the anterior nuclei of the thalamus. In the top of basilar artery syndrome, however, the infarction, in addition to these two areas, may also involve the PCA territory, and depending upon its proximal extent, may involve the superior cerebellar artery, causing involvement of the superior cerebellar hemispheres, especially the Bermans. And if the infarction is further proximal, it may also involve the pontine perforators. So the ischemic patterns of artery of Percheron infarction may involve, as I said, the paramedian thalamus, may also involve the anterior thalamus and the midbrain in combinations. So the major pattern of distribution that is seen is the involvement of the paramedian thalamus as well as the rostral midbrain, and it typically, in 50% of these cases, it involves the interpeduncular cistern, producing a V sign in 50% of these cases. The other pattern that can be seen is bilateral thalamus involvement without midbrain involvement. These are the two most common presentations of the artery of Percheron. Now, dealing with the caveats, the patient has had a recent major surgery. So as per the guidelines, a patient who has had a recent surgery within 2 weeks, the risk of surgical site hemorrhage is higher, and these should be discussed with the surgical team, should be informed to the patient and the attendants, and the consent should be sought that what are the risk and benefit that we are dealing with while we are thrombolizing. Regarding the European Society of Organization, which suggested that when the surgery has taken place on non-compressible sites, that is like the abdomen, chest, well vascularized tissues or large arteries, then the IV thrombolysis should not be considered, since it involved a compressible area around the lower leg and around the thigh. So it had a relative contraindication. Now, regarding the lower molecular weight heparin dose, since 2015 up till 2015, within 24 hours, any dose of low molecular weight heparin was considered as a absolute contraindication for thrombolysis. However, 2018 recommendation of the ASA/AHN henceforth, it is only for the therapeutic dose of the lower molecular weight heparin within 24 hours. That is a contraindication. For prophylactic doses, it is a relative contraindication. So this is how we have become a little wiser from the 2015 to the 2018 guidelines and henceforth. Regarding the third caveat, the diffusion flare positivity. Well, we have had a lot of discussions regarding diffusion flare mismatch. I think this should be considered for patients when the ictus is not clear. When the ictus is clear, we should always look for the clinical situation and the diffusion mismatch. A clinical diffusion mismatch should be sought rather than diffusion flare mismatch, because flare positivity has been documented in up to 15% cases within 3 hours, and it may remain negative also for the first, in certain cases, even up to 6 to 8 hours. So why to thrombolize and early thrombolysis? Because as we know, time is brain, we have to act fast. The NNT increases every 20 minutes. Every 20 minutes that we are going to delay, the NNT is going to rise and the risk and benefit ratios are going to worsen. So why tinnitus? As per the meta-analysis that was done by Huang colleagues, they found that the fibrinolytic disruption and the plasminogen activities were fairly much better with the tinnitus, and thereby it produced a lower risk of intracerebral bleed. It has 15-fold higher fibrin specificity as compared to alteplase. It has an 80-fold increased resistance to binding to the plasminogen activator inhibitor, and has a 4-fold prolonged plasma half-life as compared to alteplase. As we know, it is a single bolus. It is more effective in the platelet-rich thrombi due to its high resistance, and it lacks the procoagulant effect as was there with the alteplase. So what are the learning points? The learning points that we realized was that we need to stay updated. The guidelines have changed the lower molecular weight heparin indications, contraindications from 2015 to 2018 regarding prophylactic versus therapeutic dose usages. We need to be thorough with regards to review of a particular drug. A contraindication can be absolute or relative, and we should weigh the pros and cons of the procedures or interventions we are about to perform. We have to take a detailed consent. We have to have a detailed discussion with the attendants, and we have to take them into confidence prior to stating the risks and benefits of the procedures that we are providing. And we should always know the guidelines are only there to help and guide us. And a thorough clinician should always trust his gut instinct and take the best therapeutic possible decision at that moment. Thank you.
Thank you, Dr. Rehani.
Thank you, sir.
It's a very interesting case, and I would say sometimes there is a dilemma about whether we should treat, we should not treat, the risk and benefit. We have very nicely, described all the scenario. So I request my colleague, Dr. Arun Garg, to initiate the discussion, please.
So, Varun, this case, one learning point most important is when there is dilemma about diagnosis, what is the etiology. And if you are not certain of where the site of lesion is, MRI is the investigation of choice. Imaging of choice is MRI. This is very important.
Yes.
Second, this flare diffusion mismatch is only for wake-up strokes or when time of onset is not known. Not consider this mismatch. Don't even look for this. Even there is a well-formed infarct on flare, I'll thrombolyze if patient comes within 4.5 hours.
Absolutely.
Third is this Clexane prophylactic dose or full dose. I have seen, and I have thrombolized many patients if dose is given 12 hours prior. The half-life of this low molecular weight heparin is less than 12 hours. So if it was given 12 hours before, thrombolize. Or if patient is, you want to shift patient for surgery, you can do surgery after 12 hours of Clexane is given. Clexane after 12 hours should not cause any bleeding complication. And of course, if bleeding complication is any surgical site which is compressible, definitely this is not a contraindication. Only thing which I could not understand why this patient was put on aspirin and atorvastatin. Apixaban is fine, cardiomyopathy with atrial fibrillation, apixaban is the drug of choice. Again, there is controversy. Lone AF, apixaban is fine. Cardiomyopathy with atrial fibrillation, I'm not very sure whether acetylom or warfarin or apixaban, point of discussion. But why aspirin or atorvastatin?
So this patient had a dilated cardiomyopathy, which was of ischemic nature, and the patient was already on single antiplatelet and statin. So we had stepped up the statins to a higher dose. And once the Holter had shown atrial fibrillation, we had added apixaban.
So my question is, if patient is not having any atherosclerotic risk factors, would you put all such patients on aspirin and atorvastatin? I don't start atorvastatin or aspirin in any such patients. I think anticoagulant is what is required. There is no need to add aspirin and increase the risk of bleeding. And atorvastatin, if there is no atherosclerotic risk factor, I have strong doubts. But is there any role of atorvastatin in such patients? Jen.
Yeah, good point. First of all, if it is of ischemic origin and the patient has got a stable coronary disease, then usually NOAC is sufficient. Only in case of recent PCI or ACS, where we need antiplatelet coverage for certain duration, at least for the first 1 year. Regarding the statin, well, if they do not have atherosclerotic vascular disease elsewhere in the body, including coronary, then the LDL target is not that rigid, and we do not need to pump up the statin routinely for all cases. So I think in these patients, they already have a lipid profile done in the hospital, and if they are already on therapy, their LDL must be below 100. So below 100 LDL or somewhere around 70 is a comfortable range. We don't need to pump up further. So that is one point. And the another point, which was Dr. Garg was discussing about this heparin or LMWH and therapy, which is correct. More than 12 hours, probably it's out of the system, at least not in the danger zone. So we can go ahead. If by any chance, the patient got within, say, a few hours, and this is a difficult situation, we don't have clear answer to that, how we revert, because there is no specific agent available. It is also mentioned that protamine can give some reversibility, even in LMWH. It is specific for unfractionated heparin. It can give some. So if there is some compelling situation, we have to do something and know how to. So for the benefit of the patient, sometimes we use it and do some procedures. This is one point. So, Dr. Sontake, is there any comment from your end?
Yes, one more point, controversial point is that in acute stroke setting, whether statins are having that pleiotropic effects. So that way we are advisable to give statins in acute stroke, because plaque stabilization to whatsoever pleiotropic effect that plays. So
yeah, that is true. That is true, and especially large vessel atherosclerotic disease or patients where we do not know the stroke mechanism yet.
Yeah.
But in this patient, probably we have some idea about the stroke mechanism in this case, and the patient has got a vascular imaging done also. which does not show any significant atherosclerotic disease in the posterior circulation.
Yes.
So in that case, probably the indication is not that compelling. But anyway, we have to give statin if the patient has got coronary artery disease, with keeping the LDL target in our follow-up. That's it. So any other comments, Dr. Gaurav?
No, sir.
Any questions from the audience, Dr. Onkar?
So we do not have any questions as of now.
Okay, so I think we can go for the next case, and it was a very interesting case, very practical problem, and must congratulate for treating this patient courageously for the sake of the benefit of the patients, and it worked out well. So that is actually the job of a neurologist on ground, where you have evidence, weak evidence, moderate evidence, but your judgment is the most important in real time. And we have done the right thing. Congratulations. Thank you.
Thank you, sir. One last thing that I would like to say about this case was that the artery of Percheron infarcts usually do not have a very good prognosis, sir. They usually have a very poor prognosis. In 50 to 70% of these cases, they may have a very poor functionality of MRS2 or more. However, with thrombolysis, we were able to save this patient despite relative contraindications of whatever he had at that moment. And we were lucky enough to have a good functional outcome in this patient, sir.
Absolutely. Agreed.
So, thank you, sir.
So, thank you. So can we have the next presentation, please? Is Dr. Gaurav ready now?
Hello.
Yes,
hello.
you are audible. We can see your slides. Please go ahead.
Am I audible, sir?
Yes, you are. Go ahead.
Good morning, sir. Thank you for giving me this opportunity. I thank Emcure Pharmaceuticals, Dr. Jayanta Roy, sir, Dr. Santosh, sir, and Dr. Arun Garg, sir. After this in-depth discussion of this interesting case, rather this is a more of a textbook case where patient came in the window period and was thrombolized. The situation in which we thrombolized was a little interesting. I'll share the slide. So this it is a 48-year-old right-handed man, businessman by occupation, was brought to the casualty with complaints of sudden onset of left upper limb rather than lower limb weakness and slurring of speech of 2 hours duration. He was apparently asymptomatic. When while he was in his morning walk, he suddenly developed heaviness in his left upper limb.
Gaurav,
sir,
we cannot see your slides. Slides are not moving forward.
Let me check, sir.
Make it full screen, please.
So it is full screen.
I think there is some problem for sharing. Can you please unshare and share once again? It has frozen.
So you can stop sharing and then reshare again.
I'll do that again.
Yes.
Can we see now?
We can
Yes,
see.
slides are visible, sir. You can just put it on full screen.
Are they moving now?
No, sir. It's still on the first slide.
Now?
This is very interesting because we can see the first slide. We cannot see it moving. Sir, do you want me to share your slides?
Yes,
because
that would be fine. Yes, that would be fine.
Yeah, if you have it, please do it.
I would request RX Events to give me the host rights and I'll share the screen on behalf of Dr. Gaurav.
Okay, so Gaurav, please unshare your slide so that he can.
Yes, I have stopped sharing my slide.
Let me know, sir, if the screen is visible and also when to move to the next slide.
Yes,
It's perfect now.
we'll move forward to the case, please, directly.
Okay.
Next.
So this was a 48-year-old right-hand man, as I said. He had weakness of left upper limb and slurring of speech of 2 hours duration. When he was while he was in his morning walk, he suddenly developed that he could not lift his left upper limb and had difficulty in speech. Initially, they tried some local treatment there, massaging and taking rest, but as symptom did not subside, by 2 hours time, they get to the casualty. And on history, he said that initially his weakness was so profound that he could not lift his arm, but now this weakness felt better. Can we move forward, please? Yes, he also had complaints of slurring of speech, such that he had difficulty in pronouncing words, but we could understand what what he is saying. Next, please. So, except for this weakness, he had no other symptoms. He also had no symptoms suggestive of chest pain, sweating, or palpitation. Next, please. On detailed history, he was an hypertensive of 3 years duration, was on regular treatment, and he was a tobacco chewer and consumed vegetarian diet. Next, please. So on examination, initially blood sugar levels were done, which was 146 milligrams per deciliter, and NHSS was calculated, for which he had left human type of facial palsy, for which 2 points were given. Left arm weakness was there, for which 2 points. Leg motor, he could lift his arm but could not sustain, for 1 point for that, and dysarthria 1 point. So given he was in the window for stroke and had strong suspicion, initial CT brain plane was done, for which next please. This CT scan was almost for normal. Aspect score was 10. So the patient was given the option of thrombolysis, but initial for first 15 or 20 minutes, they had their own discussions and were like, stroke is improving. There is no need for this costly treatment, and I had explained them a risk of bleeding of 1%. They were like, if bleed happens, then our stay will increase. Symptom is improving, so we do not want to get thrombolized for now. Then I insisted, then I suggested them a benefit of stroke and further worsening can be there. Then one relative came and he consulted some doctor in another city, which he said, okay, now you can go ahead for stroke. Then after, next please. So after detailed discussion about the risk and benefit, ruling out the contraindication and obtaining written consent, patient was thrombolized with injection tenecteplase 14 mg. And after thrombolysis, he was, next please. He was monitored for any worsening of symptoms for next 24 hours, which he did not have. He underwent his routine investigations, which were taken before thrombolysis. And except for his HbA1c borderline level, all other tests were normal. Lipid profile was normal. So patient was given best medical treatment possible in next 24 hours, and an MRI scan was done. Next, please. So when MRI scan showed cortical infarcts, and relatives were discussed regarding this, then they got convinced that yeah, the decision which they took initial for to undergo thrombolysis was correct. Rather, this would have led to a permanent deficit. So after 24 hours of thrombolysis, patient, except for mild difficulty in speech, had regained his power in his upper limb and lower limb and was ambulant without support. Next slide. So patient was started on dual antiplatelets and statin. Blood pressure was stabilized with telmisartan. Physiotherapy was advised and was discharged in hemodynamic stable condition for full-term monitoring, which he got yesterday, and it did not show any AF. So the take point is that as we long discussed this, thrombolysis has to be done, and this a good awareness among the population is must, so that they reach within the window period, and identifying the stroke in hospital and early intervention helps in patients better outcome. Thank you.
Thank you, Dr. Gaurav. I request Dr. Sontake to initiate the discussion, please.
Yes, this is a very straightforward case. We need
Yes.
to convince people about the need of IV thrombolysis, and we have to bust their myth about the fear, because this is a now standard of care for acute stroke, IV thrombolysis. So,
Even though people don't reach, in my setting, people don't reach within the window period. Those people who reach have financial constraints, or they are little skeptical to undergo thrombolysis. So this is was a typical textbook case where a patient came in window period and was thrombolized.
yeah. So we have to tell them very firmly and in a very confident way,
Way.
okay, this is the most beneficial treatment, and very time sensitive. So if you delay the treatment, then that is a problem. Okay. So I want to ask one question. Okay, now DCJ has approved in Indian setting 0.2 dose, but all these recent trials they are using 0.25 milligram per kg dose of tenectal. So what we are using it, Dr. Roy?
Yeah, I think this is the question I was about to ask at the end to Emcure people. Are they going to apply to change their leveling in India now? Because now it's everywhere 0.25.
Yeah.
And we have 0.2 here, though.
I have, sir. I had one rather than
Unofficially,
uneventful event where
we give 0.25, right? Yeah, go ahead. Tell me.
so I had one rather than
Dr. Gaurav, you
uneventful
are telling
event.
something?
Yes, sir. I had an uneventful event where after 0.25 mg of thrombolysis, rather the window was almost 4 hours. Patient developed bleeding. So I think 0.2 is better drug rather than 0.25, but that needs to be confirmed. That needs to be confirmed by trials, I guess.
Bleeding can happen with any cases of thrombolysis, even you are on the copybook. So it depends on the odds, and the law of average will catch up you someday. So you have your bleed day someday, we have to handle it. But that doesn't deter us to do the right thing at the right time. So I think practice is practice. You follow your protocol, follow your evidence and your judgment, and treat the patients. As I was telling that, I think 0.25 has emerged as the standard dosing for tenecteplase plays all over the world, except in India at this moment because of the approval thing. So maybe that will be taken up later on and will be aligned with the worldview very soon. So, and regarding your case, I have just one quick comment. This was a minor stroke. So minor stroke patients, they do improve very well. So was there any vascular imaging done in this patient? Do you do vascular imaging in acute stroke run like a CT angio or MR angio at the beginning?
At the beginning, we do only CT brain plain, sir. After 24 hours of say thrombolysis, I get an angiography done. If angiography is not available, then I get at least carotid done for intimal thickening or any plaques, if we can see.
Well, I think, yes, the decision of IV-TPA can be made only based on a non-contrast CT scan and a clinical assessment. But in the days of mechanical thrombectomy, and when a minor stroke can have a major vessel occlusion sitting. So minor is not always a minor. So if you have that information handy, that this patient has got a say M1 occlusion or one of the, proximal M2 occlusion, and the patient has got a minor stroke, and this patient might not improve with your IV-TPA, rather the patient worsens, then you know that I have an LVO so that you can proceed with the next step. If you have the information handy, otherwise. So I think the protocol having a vascular imaging at the beginning is immensely helpful for us these days. So that is one point. But otherwise, whatever we have done, it's perfectly okay. And as Dr. Sontakia was telling that your counseling in the emergency room is the key.
Yes.
Is the key. And that makes all the difference. So, Dr. Garg.
So, Gaurav, this minor stroke is no longer a contraindication for thrombolysis. Improving stroke is no longer a contraindication. And how you do counseling is most important. So, in my experience, the rule is if lesser is the patient's age, if patient comes to you early, and if NHS score is less, and if aspect score is high, and if patient is not having any significant comorbidity, please go ahead. You tell the family that benefit is much more than risk. If this patient is not thrombolized, risk of having stroke and disability is very high. But benefit of is much more than risk. And if my family member has suffered from similar stroke, I would go ahead. तो मेरे साथ यदि होता तो मैं कहता कि थ्रोम्बोलाइज करो, ये बोलना ही important है. So you it should come in your face, on your face, and in your voice. So the confidence hota hai, that pays. Second, in periphery, we understand that the vascular imaging is not available, CT angio, MR angio is not available. Then definitely you'll have to follow whatever is available. You have to follow that. Otherwise, if CT angio can be done along with this plain CT scan, then definitely it helps in better management of patient.
Absolutely. And it all depends on your workflow. I mean, if you believe that CT angio is going to take a longer time, so I recommend those centers that based on CT these days, you start the thrombolysis, give the bolus, or in case of tenecteplase, it's a single. Then put the patient back on the scanner and complete the CT angio. Because if the CT angio takes another 30 minutes, then it's a delay. So anything should not delay your door to needle time. It may be 5 minutes we can tolerate. If your system is geared up to do the CTA and CTP, if the protocol is like there, quickly. Otherwise, do not delay. Put the patient back on scanner and complete your CTA. If your CTA is clean, then you are relieved that probably you don't need to go for any mechanical. But otherwise, it's helpful.
Sure. Thank you, sir.
Okay. Thank you. And I just one question. It may not be relevant. Why did you do a TROP-I? Is it a protocol for your institute?
Yes, sir. We have developed a flow where each patient with a thrombolysis, we do a complete cardiac evaluation, including ECG, echo, and TROP-I, sir.
The ECG, echo, I understand, because you need to know the cardiac chambers, the valves, the contractility, and the rhythm, of course, later on to know the mechanism. TROP-I, until and unless you do have any history of any chest pain or anything suggesting symptom, TROP-I is usually do not order. So that's okay.
In window period, we have only BSL, random BSL we do, unless some history is there of anticoagulation or anything. Other than that, we should not delay the thrombolysis therapies. Only
so Gaurav, you do echo before thrombolysis?
No, sir. That was after thrombolysis.
The
samples were taken before thrombolysis, and
after thrombolysis, whatever you do, it's not going to delay your treatment. So that has to be kept in mind. And technically, other than a blood glucose, probably you don't need anything. Just a capillary glucose. And if there is no history of any coagulation disorder, liver disorder, kidney problem, then we just don't wait for anything. Just draw the sample, go ahead. That's it. So I think we had two interesting cases, though standard, but important points we have discussed, we have covered. And if there is any questions from the audience, we'll be happy to check them.
So there are several comments like, nice presentation, nice discussion, but there's no question as such. So we have a lot of comments.
Maybe we have answered all the questions upfront.
Right, sir.
Good for the presenters. good presentations in that way. Excellent.
Thank you, sir.
So I think we are on time almost. And is there any comment from my colleagues, the moderators, or we can wrap up the session?
So I had just one doubt, sir.
Yeah.
So we are mostly using the dose of 0.25 mg per kg for the 10 days. Do you use a lower dose like in patients who are having a higher risk of bleeding of 0.2? Or you use just one dose of 0.25 milligram per kg only?
No. First of all, we don't have that evidence, neither we have any rationality at this point doing that. If the patient has got a higher risk of bleed, we don't thrombolize the patient. But if we thrombolize the patient, if we decide to do it, definitely the benefit is more than risk. And explain them, of course, the risk is more because of these other reasons. But there is no point giving a modified dose. Don't find any rationality. I mean, you might be referring to the trial on alkylase, but the 2/3 dose, the Japanese trial, 0.6.
Yes,
but again, if you contemplate that, then we need another trial to prove that in elderly with this 0.2 or maybe less dose is equally effective. Until then, standard dose applies.
Okay, sir.
Right. So, Dr. Onkar.
So Dr. Onkar seems to be having a technical issue today. So I would like to extend the vote of thanks on his behalf. Any final comments from the other moderators, and then we can have the vote of thanks.
So I think we can go ahead.
Yeah.
And now conclude.
Yeah. So I think we've had a great Sunday morning with the two interesting cases that we have discussed. I would like to thank the delegates who have joined us on this Sunday morning. Thank you so much for joining us and making this KT series a grand success month on month. I would like to thank the two speakers, Dr. Varun and Dr. Gaurav, for coming forward to share the cases with us on this platform that enabled this session. So thank you very much, Dr. Gaurav and Dr. Varun, for the excellent case presentations. I would also like to thank the two moderators, Dr. Arun Garg and Dr. Santosh, for sharing their expert comments on the two cases and making this discussion very lively. And last but not the least, a very, very big thank you to you, Dr. Jayanta, for being a constant guide to us. And whatever success this series has seen, you have a very big part to play in it. You had a very big part to play in it. So thank you very much. And we will come again next month with another episode of No Thrombosis. Till then, thank you very much and have a very nice Sunday.
Thank you. And just before we hang on, I think I must mention that in the KT, what I found that this joining this young neurologist on this forum, like Dr. Gaurav and others, the older people, we feel more energetic. We get some energy imbibe from them, and that gives us an excellent kind of interactions with our younger colleagues. They have been doing great work. They're sharing their experience with us. So it is another unique thing of KT in that way. So I can congratulate Emcure for conceiving this idea of having this series, though in the pandemic, but we continued post-pandemic because it turned out to be a very interesting one. Great one. Thank you.
True, sir. True. And I think it is both ways. The younger generation is benefiting from your experience and your expertise.
Absolutely.
And you feel lively thanks to the younger generation coming on the platform, sharing their cases.
Excellent. Okay. Thank you. Bye, everyone.
Thank you
Have
so
a nice
much.
Sunday.
Okay.
Bye.
Awesome.